Good morning, everybody. Welcome to the InTouch Health webinar series. This is Scott Young, and I'll be your host for today's webinar. Today, we'll be featuring Sharon Allen, who will present about World Telehealth Initiative and their mission to bring healthcare to under-resourced regions of the world. Sharon Allen is the co-founder and executive director of World Telehealth Initiative. Under her leadership, WTI has developed an innovative model that leverages remote philanthropic physicians to provide care via telehealth. Since its founding in 2017, WTI has established remote specialist care and training to on-site providers in 15 underprivileged communities throughout the Global South. Previously, Sharon managed a successful distribution corporation for 25 years, holding executive leadership positions with the last 8 years as CEO. She grew revenues from 20 to 30 million while achieving record profits and leading a team of 75 employees. Sharon has been selected to serve on the World Health Organization Digital Health Board of Advisors roster of experts. Over the years, she has served as board member and financial chair of the Apple Foundation and volunteered in nonprofit organizations such as St. Joseph's Hospital, Dream Foundation, and Children's Creative Project. The presentation will begin shortly, but first, a few notices. You have all been auto-muted, but if not, please make sure you mute yourself. During the webinar, you'll be able to enter questions in the questions widget located on your audience console. Questions will be answered at the conclusion of the presentation, so please feel free to ask your questions at any point throughout the webinar. If a fuller answer is needed or we run out of time, questions will be answered later via email. This webinar will be recorded, and a copy of the recording will be available on our website and sent to registrants. This webinar presentation should last about 60 minutes, including time for questions and answers. And now I'd like to turn it over to Sharon.
Thank you, Scott, and thank you everyone for joining us today. As was mentioned, World Telehealth Initiative, or WTI for short, began 3 years ago. The idea originally was conceived by Dr. Yulin Wang, who many of you know to be the founder of InTouch Health. With 17 years devoted to telehealth, he realized that those most in need of increased healthcare access are those that are least able to afford the advanced technology. However, with minimal additional load on the global telemedicine network that InTouch developed, it can be utilized to serve under-resourced communities throughout the world. With that concept, we formed a vision and created a model. Our vision is to revolutionize global healthcare and to provide a solution to the healthcare delivery crisis. As we explore the expansion of healthcare access to under-resourced regions of the world via telehealth, I'll share about our work and will simultaneously address the learning objectives listed. When we analyze the lack of access and means of healthcare in under-resourced areas, we find that the World Health Organization tells us half of our world can't access needed health services. There's increasing efforts and reforms and leadership attention in the last 5 or 10 years or so, and most parts of the world are seeing an expansion in access to health services, but there's certainly a long way to go. Contributing to the lack of access, there's an estimated shortfall of 7.2 million health workers. And let me put that in perspective. For example, there's only one oncologist in the entire country of Bhutan, and cancer is among the leading causes of death there. There's one pediatric surgeon in southern Malawi trying his best to serve 6 million children. Many African countries have only one neurologist, and few have no neurologist. And while the US has 5% of the world population, we have 30% of its psychiatrists, which leaves some countries without any mental health support. Finally, we have the problem of brain drain. In low resource settings, doctors face challenges such as a heavy workload, insufficient training, medical supply shortages, low salaries, poor recognition, and even frustration with not being enabled to perform according to common professional standards. So many doctors abandon their jobs and seek greener pastures in the US or elsewhere, which creates this brain drain and furthers the physician shortage. I'm sure you've heard people complain of a physician shortage here, but when we look at global statistics, the numbers are really staggering. According to the World Bank, we have one physician for every 400 people in the United States. And then you see at the far end of the spectrum that places like Malawi have one doctor for every 60,000 people. And health workers are distributed unevenly. So many places within the under-resourced countries have either very few experts or possibly none at all. Countries with the lowest relative need have the highest number of health workers, and those with the greatest burden of disease make do with a much smaller health workforce. So we need to think about redistributing the concentration of medical expertise. When we look at a few more numbers, the fact that 8.6 million people die each year from treatable causes is astounding. And we see that the majority of them received care, but that it was substandard. So access and affordability of health services alone is not enough, but the health care also needs to be of high quality. I'd like to share a story of what it can look like when a patient seeks care, but the expertise necessary is simply not available. This is Esperanza. At 19 years old, she and her husband were expecting their first child. She began to labor at home, but after 2 days, she knew she needed to get to a clinic. And Malawi has actually done a good job of educating pregnant women on the benefits of a supervised birth. But she couldn't afford to have a car and driver take her to the nearest clinic, so she opted to travel by bike. Esperanza sat on a tiny seat while she was in labor for 6 hours en route to the clinic. When she arrived, the clinicians were able to give her pain medication, but unfortunately, that is all they could do for her. She labored for 2 more days and eventually delivered a stillborn baby. Although a C-section would routinely have been provided in our country to alleviate an obstructed labor, that option is nearly non-existent in Malawi. The expertise she needed was simply not available. Remember her, sweet face, and we'll return to her later in the presentation. In today's world, we have a compounding complication on top of our already dire statistics. The fragile health systems in underserved communities are being further tested by the COVID-19 pandemic. They're struggling to meet the needs of the new outbreak, ideally without erasing their efforts to treat existing illnesses. And the pandemic has proven that global health is really only as strong as the most vulnerable community. There's many organizations around the world working to address healthcare issues, but the efforts are often episodic in nature. For example, medical missions create tremendous value when they visit the areas of need, but when they leave, the void of care returns. Trips are expensive and they require doctors to clear their calendars for a week at a time. So many doctors are simply unable to participate. And other organizations attempt video conferencing, but frequently they use a lower quality technology that can prove to be unreliable. World Telehealth Initiative works to provide sustainable medical expertise to the world's most vulnerable communities in order to build local capacity and deliver core health services. And we do this through a network of volunteer healthcare professionals supported with state-of-the-art telehealth technology at little to no cost for the patient. So let's examine telemedicine as a solution for access to care. We know there has recently been rapid adoption of telehealth in the US and other high income countries as a means to deliver more accessible, lower cost, and higher quality healthcare. COVID-19 empirically demonstrates telemedicine's transformative effect on healthcare delivery, but under-resourced countries do not benefit from this new technology because of cost. WTI is in the unique position to provide telehealth to these countries, regardless of their ability to pay. And our goal is to bring it to more impoverished areas of the world. It's predicted that up to 50% of medical appointments will be virtual within the decade. And the time is now because we have this incredible technology that enables this healthcare delivery. As Director General of the World Health Organization, Dr. Tedros Adhanom Ghebreyesus says, COVID-19 has shown us that disease outbreak anywhere is a threat everywhere. We must stand together to support all countries and ensure equitable access to life-saving technologies. Scaling up access to medicines and health technologies in these countries is essential to slow new infections and avoid unnecessary deaths. With WTI, our model starts with the generous donation of technology from InTouch Health, which will soon be Teladoc. Not only do they grant access to their worldwide network, but they supply us with virtual care devices we use. And at the bottom, you see we collaborate with an ecosystem of other organizations for their expertise, which may include shipping, logistics, or healthcare volunteer groups. But most importantly, we have our volunteer physicians that are really the lifeblood of our programs. There's a multitude of humanitarian doctors that want to help the underserved. They're the true superstars that are giving their time and expertise. A study conducted by UCLA found that doctors have a high desire to help the underserved, and 80% of surveyed healthcare providers were interested in volunteering. We're often asked how we recruit our supporting physicians. But the fact is, not only are they altruistic, but between the ease of InTouch technology, along with the training and support from WTI, it's really almost effortless for them to participate. A doctor can simply grab his laptop, go sit in his favorite armchair, enter a few keystrokes, and boom, he's in Ethiopia, for example. He could consult for 45 minutes or so and maybe see 3 or 4 cases that the local provider needs assistance with. It's really that easy, and we have a team of amazing supporting physicians that are doing just that. Every week, we add new doctors. On the other side of the equation, surveys reveal that assistance is requested by the vast majority of low-resource clinics and hospitals. They ask for both training for their care providers as well as with patient treatment. At WTI, our underlying objective is to build the capacity of the local provider. Thereby, we ultimately strengthen the resource-poor community. So the responsibility of care always remains with that in-country clinician, and we strive to empower them to care for their own. So patients gain access to advanced healthcare with every WTI consultation, and each encounter is an opportunity for the local clinician to increase their knowledge and acquire new skills. And with this, the confidence and professional satisfaction increase, encouraging them to stay on the job where they're desperately needed. When we build a program, we work with each site on an individual basis to address their specific requirements and their concerns. We believe that the hosts should be fully engaged in the program design because only they really know their resources, their needs, and their capacity. This individualized, needs-based collaboration takes more time and effort, but it promises better long-term sustainable results. Currently, we have 15 programs that are demonstrating expanded healthcare access in under-resourced regions of the world using telemedicine. The red dots indicate our current program sites, and the yellow dots represent programs that we have qualified and are in various stages of implementation. We've made significant strides. Our 15 programs were launched with a small budget and minimal staffing, but due to the leveraging of donated technology and abundance of donated physician expertise, we've seen compelling results and proven that our model does work. The fact is, we have thousands of physicians asking to join our programs, and we're aware of the needs faced by thousands of clinics and hospitals. So WTI uses an algorithm that we've developed and continue to refine to match the ample supply of medical expertise with the immediate demand of the underserved communities. So we consider factors such as pairing the clinic's needs with the specific requested expertise. We have to look at schedules and time zones and volunteer physician availability. We ask if there's a particular country of interest or if the physician is diaspora, hoping to serve their homeland. And we often work with existing relationships that we can make sustainable and increase their impact. For example, often universities or teaching hospitals already have affiliations with hospitals in low resource areas, and we make those connections sustainable. So they may travel, once a year, but we can keep those programs going, 365 days a year. Now we can address our final objective to evaluate strategies for use, benefits, and obstacles that may be encountered when trying to provide remote care. And let me start with the obstacles. A potential one could be around cultural awareness. We try to mitigate that as much as possible with an orientation packet that includes information about the country, culture, and specific healthcare system that the physician will be working with. We also arrange a virtual meeting to onboard new volunteers with the site. Oftentimes questions are asked about what supplies are available or what types of conditions they're most likely to encounter. Many of our volunteer medical professionals are diaspora of the countries they're serving. So they're already familiar with the culture, which of course is a fantastic combination. Over time, we see the relationships develop between the physicians on both sides, and a few of our participants have eventually even visited the country they're supporting. One doctor was saying, I have to meet my colleagues on the other side, and I want to see the community that I'm serving. And as far as strategies for use, physicians can provide services in the following ways. There's over 1.2 million nonprofits worldwide that work towards improving health and well-being, but we're the only organization I'm aware of providing our unique services in the following manner on a philanthropic basis. A few others may incorporate telehealth, but a differentiator is that most of our sessions are real-time, while others are mostly asynchronous, yielding medical expertise in 24 to 48 hours. So I'll walk you through these 4 different interactions. Regarding emergent high acuity use cases, we're now supporting 2 remote children's hospitals in northern Argentina with the requested pediatric cardiology and neonatology specialists. And in Argentina, they rank levels of acuity from 1 to 6. Previously, these 2 sites were allowed to care up to level 3, and all the other pediatric patients would immediately be transferred to Buenos Aires by a 2-hour flight, which sometimes resulted in unfortunate outcomes. But now an expert can beam in to assess the child, possibly provide a local care protocol, or maybe stabilize that child for a successful transfer. These two programs are both supported primarily by a team out of a large referral pediatric hospital in Buenos Aires. So they can assist real time in high acuity emergency situations. With surgical mentoring, it allows an expert to guide or mentor a novice surgeon through a procedure. And with the Zoom capability, it's easy for the mentor to see the surgical field and guide the local surgeon. As an example, allow me to finish the story of Esperanza in Malawi. Due to her prolonged labor without appropriate medical intervention, not only did she lose her baby, but she suffered from an obstetric fistula, which is a devastating condition that leaves a woman leaking urine or feces indefinitely. Fortunately, Esperanza won't have to live the remainder of her life in shame and isolation like many of the other 2 million women that suffer from fistula do. We enable expert fistula surgeons from Baylor College of Medicine in Texas to regularly beam in to support and train the resident surgeon on complex cases at the Fistula Care Clinic. Esperanza had a double fistula, but is now healthy and has returned to her previously happy and productive life. In addition, after 8 months of frequent mentoring, the novice surgeon acquired the competence to handle her complete caseload independently. So a precious patient accessed quality health care and the capacity of the local health system was increased. Rachel, could you advance the slide, please? Thank you. Scheduled clinical consultations. They involve patients with particular needs that are matched to an appropriate specialist that beams in at a predetermined time, and they're able to evaluate the patient's condition through a live virtual exam. We have a robust program in Bangladesh in the local community of Cox's Bazar and also in the adjacent Rohingya refugee camp. And these two programs have been so successful in providing various medical expertise that both locations have hired a dedicated physician to channel all of the available expertise for their local communities. Peer-to-peer didactics is really a constant for all of our programs, as our goal is to increase the development, training, and retention of the health workforce in the under-resourced communities. And this may be classes on topics of interest for the on-site teams, or it can be a simple one-on-one with the in-country doctor asking for support from a specialist. And a perfect example of this is with our COVID response. For example, Hope Hospital in Bangladesh requested support for the development of a 50-bed isolation ward in the refugee camp. They had questions regarding supplemental oxygen options and what necessary labs they needed to incorporate. And even questions regarding the construction of a negative pressure room. So we were able to match them with infectious disease experts that were on the front lines in the US that were gaining daily experience with COVID. Then when the isolation bay is finished, we will link remote specialists in infectious disease as well as pulmonology and anesthesiology. Although the nearly 1 million Rohingya refugees are tightly packed together in the camp, Hope Hospital staff says that telemedicine gives them hope to restrict the disease spread and isolate and treat infected patients according to WHO guidelines. The CDC states virtual care is among the best recommended solutions for social distancing and mitigating the spread of COVID-19. There are roughly 500,000 physicians in the US using or wanting to adopt telehealth. If each of these physicians are willing to donate an hour a week, that would result in 26 million hours a year. Typically, 4 virtual consults can be done in an hour, which gives us the ability to treat over 100 million patients per year using telehealth. And that's just the US doctors, but physicians can be from anywhere in the world. Some of ours are in country, as in Argentina, or our program in Puerto Rico. We also have doctors from the UK and France and Canada. So it isn't a real stretch for this to become a reality. One thing the pandemic has reminded us of is that the health of all people around the world is deeply interconnected, and so too are our health systems. We can improve our systems and healthcare delivery by utilizing telehealth technology in partnership with our colleagues in under-resourced regions of the world. If you would like to transform global healthcare, if you're a physician and are interested in joining our efforts, or if you're affiliated with a low-resource healthcare site internationally that needs sustainable medical expertise, please let us know. Thank you for allowing me to share about World Telehealth Initiative, and I hope you increased your awareness of expanding healthcare access to under-resourced regions of the world.
Great. Thank you so much, Sharon. So again, we're at the question and answer portion of this webinar. So please make sure to get your questions through the question widget located on your console. I'd like to remind everybody that if some questions require further answers, or if we don't get to all of them, we will be able to answer them offline via email after the presentation. So first question I have for you, Sharon, is how are you addressing the gaps in connectivity and access to electricity in low and middle income countries needed to deliver clinical services and education?
So we have been fortunate in that we have had very few glitches with the system. In the case of surgical mentoring in Malawi, they were very aware of when their bandwidth was strongest. And so oftentimes they would make sure to schedule the surgery when the bandwidth was typically adequate. Sometimes in Malawi in Bangladesh during monsoon season, there has been a complete power outage and the internet has gone down. And so sometimes those cases will be followed up with via email or even WhatsApp. Obviously, it isn't as ideal, but they're able to still communicate that way. Sometimes, however, the patients are rescheduled for the next day or the next week, depending on the volunteer physician's availability. But as I said, we have been very fortunate in that we haven't had much of a connectivity issue. And part of that is, of course, due to the InTouch Health network.
Great, thank you. So this next question now is regarding what type of feedback you've received from patients or providers on site to these programs that WTI is providing.
So it's interesting. Most of the providers on site do not have telehealth experience prior to us coming to their location. So the adoption phase really requires nurturing. They're fascinated by the light device that we typically deploy, but also they might be a little fearful of it. But once and they don't have to register. I mean, they aren't necessarily the ones that have to beam in. It's more the remote physicians. However, I encourage them to register and train on the platform. And then we found that, for example, in Malawi, the local physician utilized the technology frequently. She's a female, and at night, when her staff would call her concerned about a patient, Sometimes the phone wouldn't even work. It would be too static and she couldn't understand them. So she would say, wheel the device to the patient's bed, and she would beam in and have much clearer communication. So once they see how easy the technology is and they understand what expertise it's providing, then the momentum starts building. So there is a little bit of an acclimation stage, but once they're able to witness it, it's kind of off and running. And as far as patients, it's actually very cute. They are fascinated and like, what? This doctor is going to beam in. But there again, they're receiving quality health care that they wouldn't otherwise have. So knowing that, of course, makes them, fans of the technology.
Perfect, thank you. So this next question, I think where it's going at is it's asking that there's a lot of similar challenges providing access to underserved, but just here domestically in the US, such as tribal partners. Is there any vision for WTI doing anything domestically?
So we actually are asked that question frequently. And when we started, the policy was much more restrictive for telehealth in the United States. And it was actually easier for us to begin internationally. However, we are starting to evaluate domestic programs. There is also another organization that does, some domestic, it's mostly asynchronous, but they do some domestic philanthropic activity. So yes, wherever the underserved are, we are certainly willing to entertain if we could be of value there.
Excellent. This next question is asking for a little more detail on how COVID impacted WTI's work this year. Any updates that went along with that?
So, of course, when the pandemic hit, we have deep relationships now with our current 15 sites. So immediately we reached out to them and said, what do you need? How can we help? Some of them were just shell shocked and they were so afraid they kind of went offline, and that's fine. We are there to support them when they need us and when they want us. So slowly though, they began to reach out, and some of them we drastically changed their use case. For example, at the Rohingya refugee camp, it became less about treating maybe chronic diseases and more focused on, building that 50-bed isolation unit and making sure that when they received patients, that they would have the support and knowledge about how to treat them. So because of those relationships, they trusted us. They knew we could find the appropriate expertise that they needed. And then some of the sites actually had to close with COVID. So then, for example, in Malawi, they weren't doing routine surgeries, which would be considered, fistula repair. So we were able to move that device to the public hospital in Malawi, and that is geared towards HIV pediatric patients that they're concerned would have a higher comorbidity that would affect their response to COVID. So really, again, it's working with our on-site partners as finding out to what they most need and how we could best help them. In Vietnam, for example, they recently called, and they've had very low incidence. I think it's only like 300 cases and no deaths. But they kind of called in a panic and said they all wanted, more training and more support preparing for the second wave of COVID. That hasn't happened, but we're hand in hand with them in preparation for that should it happen, because that's what they asked for. So again, it's working with our partners, trying to fulfill their needs and requests.
Great. So this next question now, I think what it's trying to get at is asking, so for all your programs that you have worldwide, how big is this team of volunteer physicians and what type of specialties are there that are really standing up these programs that you have already in place?
So good question. So right now we have probably a couple hundred doctors actively working. However, we've been approached by physician organizations with 24,000 physicians that say, half of our physicians want to do this. And so we know, and we're approached every day by physicians that want to help in this way. So now we've actually just applied for a grant to help us automate the process of using this matching algorithm, because we realize that there is the supply of physicians that want to, serve the demand for healthcare. So we are ramping up our efforts so that we can address more of the global healthcare needs. Right now, we have, I'd say there's 30 different specialties that we utilize, everything from infectious disease, neurology, gynecology, pediatrics, neonatology. I don't think there has been a medical professional that has approached us that we haven't been able to find a match for. In fact, I often use the word physician, but I should say professional healthcare provider, because we've also been contacted by nurses or nursing associations that want to help in this way. And really, if we can, again, strengthen the healthcare systems on the other side, there's no reason we can't do it through nurse practitioners, nurses, or whatever it may be. So far, we are working with just physicians, but down the road, we see that even opening up more so.
Perfect, thank you. So we are almost out of questions. So again, if anyone does have any questions right now, I encourage you to add it to the question widget on your console. So this next one is asking, are there any specific specialties, or is there an overlap in all these different programs that you have that people are looking for the same types of providers or assistants? Is there anything that's like would be the most help?
Let's see, what is most requested? Some places, for example, Bangladesh, that both of those clinics were staffed by OBGYNs. They were maternal health facilities. But is what they've done, and it kind of started with the Rohingya refugee crisis when people were coming to them with all sorts of medical conditions. And bless their hearts, they wanted to help everybody, but didn't feel like they had the expertise. So these OBGYNs were channeling this various expertise until now, as I explained, they've hired a dedicated telehealth physician to channel all the expertise. But they have since gone out into their communities and, for example, at women's groups, and they say, not only can we help you at our clinic, but bring your family, bring your children, bring your husband. We can help, serve your medical conditions. And so really that is every everything is required. So again, it's driven by the local sites, and they seem to, in fact, when we ask them what are your greatest needs, they usually answer everything. So we encourage them to start with maybe 1 to 3 medical specialties, and then from there build out their use cases. So again, I don't think there's any physician that we have had to turn away because we don't have a need, because there is a need, and it's up to us to match that need with the appropriate expertise.
Great. So this next one then is asking kind of along those lines for forecasting. So just estimating a year out, how many doctors do you believe are going to be active on the WTI platform, or how many care locations do you imagine having?
So we are very optimistic that we're right now deeply concentrating on funding. We do need to grow our infrastructure in order to be able to do this on a larger scale. So if that should come through in a year, I would project that we would go from 15 programs to 30 programs. And then, in 2 years, we expect to be at 40 programs with 2,000 physicians at least on board. Um, Also, we encourage physicians when they start to maybe dedicate an hour a month, then many of them move to an hour a week. Some of them only do it sporadically. So, yes, we expect to be at least at 40 programs in the not too distant future.
Well, that's very exciting. And then for this final handful of questions, I think we can kind of group them up. I'm very encouraged. A lot of people are asking how they can get involved or how they can help. And so for that, I'd like to say that we have Sharon's email right now on these slides, as well as there's a World Telehealth Initiative's website that has a lot more information. And then I would also encourage you to register for the 14th Telehealth Innovation Forum. So it's going to have a lot more information on WTI and how telehealth can benefit patients around the world. Also, the forum is gathering industry leaders and healthcare visionaries from around the world to share virtual care best practices, clinical and business workflow models, and achieved outcomes. Also, this year's forum will be entirely virtual and 100% free. So to register, you can go to that URL right there, forum2020.intouchhealth.com. So that concludes today's webinar, and thank you so much, Sharon, for helping us with today's presentation, and thank you everybody for attending, and I hope you have a great rest of your day.
Thank you.